The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome to everyone here today to witness the next episode of TMD Demystified. My name is Tony Urbanic, and today the title of our discussion is, why does TMD often feel like an earache? Now, I've touched on this before on other episodes, but today we're going to do a more specific description of why and how that temporomandibular joint disease, TMJ disorders, frequently feel like ear pain. If you are a public or you are a dentist or other provider, you need to know this information because it has been an enigma to the dental profession almost since the beginning of the dentist trying to treat TMD. But today we're going to explain it to you and show you exactly why hundreds of thousands of people go to walk-in clinics, PCPs, ENTs, complaining of earache and end up being misdiagnosed as ear infection. What occurs frequently, and we see it constantly, almost on a daily basis, if not a daily basis, in our practice here in Middle Tennessee, in Nashville, Brentwood, patients arrive with a long history of going to medical providers who take the symptom of earache, do an ear examination with a speculum, an otoscope, a little scope that goes in the ear, looks like a little light with a magnifier on it so you can see down inside the canal. And the provider, medical provider, ENT, nurse practitioner, and convenient care cleaner will look down in there to see if they have any evidence of infection, which leads to inflammation. Infection is an infection of usually bacteria, creating inflammation, which causes the pain. One of the characteristics of inflammation is the creation of pain, besides the creation of redness and swelling. So when the provider looks down in the ear canal with a otoscope, the speculum, looks like a little funnel attached to a little light on a handle. You've probably all seen them in the doctor's offices. What they're looking for is they're looking for redness and they're looking for swelling that would be consistent with infection down in deeper areas of the ear canal. The ear canal, of course, you all know where the entrance is to your ear, and there's a canal of about a centimeter or so in length to the eardrum, specifically called the tympanic membrane. Most people call it the eardrum. And that's as far as you can see. You can see down in there as far as the eardrum, and then if there's evidence of swelling or redness, then the diagnosis is made of ear infection, at which point then a broad spectrum antibiotic will be used, the most common amoxicillin, which is a very broad spectrum antibiotic. And if there is an infection in there, we'll usually decrease the infection and the inflammation within a couple of days, and the pain will begin to decrease. The problem is that ear infection is commonly misdiagnosed when the actual diagnosis is temporomandibular joint disorder, or TMD, or more specifically, inflammation within the jaw joint. So the question is, how in the heck can inflammation, which is in the jaw joint, which should be the proper diagnosis or proper description of TMD, TMJ, should be inflammation within the temporomandibular joint, because inflammation drives all the symptoms. The question is, how can inflammation within the temporomandibular joint create the symptom of ear pain? Well, that's what we have to talk about very specifically and very easily. So first of all, let me share a screen with you and pull up a diagram of the external auditory canal and the glenoid fossa, which is the socket part of the temporomandibular joint. Let me get this going here. All right, hopefully you can see that. And let me point out a few things. This is a diagram directly out of a 1953 edition of Gray's Anatomy, which was gifted to me by the chairman of the Department of Anatomy at Indiana University when he found out that I couldn't afford a Gray's Anatomy, and he reached behind him and he gave me his personal copy. I cherish it. 1953 edition with his name on the inside cover. This diagram is, let me get you oriented here. This is the external auditory canal. This is the bony part of the external auditory canal. And this is what is called the glenoid fossa. It's the socket part of the ball and socket of the temporomandibular joint. You can see immediately how close these two items are. This is posterior. This is the front of the face out here. This is the posterior part of the temporal bone. This is the anterior part of the temporal bone. And the juxtaposition or the closeness of the posterior part of the glenoid fossa, which holds the ball and socket of the joint, to the external auditory canal. It's very, very close, and it is so close that when this particular joint becomes inflamed due to damage within the joint, damage being caused by one of three causes. Most common cause is bruxism meaning clenching and grinding. Also caused by acute trauma to the face and the jaws. Most common issue there is whiplash, which is seen frequently in automobile accidents, and then functional malocclusions where the bite is so bad, the bite is so uneven that it overloads the joint, causing damage within the joint. That is called a functional malocclusion. And the dysfunction is creating damage, and after damage, inflammation of the jaw joint itself. So for those three reasons, we get damage and inflammation in the joint. When the inflammation gets severe enough, what occurs is that inflammatory fluid can penetrate a very, very thin portion of bone, literally paper thin, between the posterior aspect of the glenoid fossa and the anterior aspect of the external auditory canal. Deeper, now the bone here is relatively thick, but when you go down this ear canal about 5 millimeters or so, you will see, and I'll try to show you that on actually a actual skull in a moment, that there is a very, very thin, paper thin portion of bone that will allow the inflammatory fluid and inflammatory cell exudate to penetrate that paper-thin piece of bone and get on the inside of the external auditory canal. It doesn't necessarily have to cause swelling and redness because it's coming not from the external part of the canal, it's coming from the internal part of the glenoid fossa, which penetrates the bone. As soon as it penetrates the bone, it stimulates the pain receptors which cover the bone itself on the inside of the ear canal. Let me be very specific here, maybe too specific. The inside of the temporomandibular joint has no sensory or sensors for pain, but the ear canal does have sensors for pain. They're located in the periosteum, which covers the bony part of the external auditory canal in 360 degrees. But on the posterior aspect here, those sensors for pain are located in the periosteum, covering that very, very paper-thin bone, which separates the glenoid fossa, socket, and the external aortic canal. So when this joint becomes inflamed, there are frequently instances where that inflammatory fluid penetrates the very thin surface of the bone and then stimulates the nociceptors covering the bone on the external auditory canal. At which point, when those sensors are stimulated, a message is sent to the brainstem saying we're inflamed, and it hurts, and the patient perceives that it's an earache because the pain is actually coming from the external auditory canal, and usually very deep inside the external auditory canal, and they claim it feels like a earache, a deep ear pain.